Thank you. So as I said, my role is to talk about the outside-in repair. And what I would like to do, outline how we use it and then go through some techniques. So for me, this is really the mid and anterior 2/3, such as we'll see in bucket handle tears, discoid lateral meniscus that may become separate from the edge, and in meniscus transplant to repair that anterior third. So I'll just run through a couple of the techniques. The meniscal meander system, I'll show you the spinal needle system, and then a single needle system. And we've just heard the principles, and I must remind ourselves of those principles to prepare the bed ready for repair. So this was first described, Russell Warren, the first attributed report to this, and note this was volume 1 of the Journal of Arthroscopy, volume 1, number 3, back in 1985. So the meniscal meander system is a neat system of needles with a wire loop that can pass down the needle. And the way for me on this, the straight needle has the wire loop and the curved needle has the suture. And we remember that, then we can pass the suture through the loop. So here's the technique. We see the meniscal tear at the anterior part of the meniscus, and we're passing the straight needle through the meniscus, and then the loop goes down the straight needle, and we use the curved needle to feed through that loop to then pass in the suture. So this will be the definitive suture that is then tied over the capsule. And that is then snared by the loop and pulled out. So we've created a horizontal or a vertical loop over the meniscus repair that is then tied over the capsule. So that's using the straight and the curved needle system. So this technique, written up from Rob Lepard's group, is using 2 straight spinal needles. So using the first straight needle with a number 1 PDS suture, which is fed through, and then that is then passed into the loop through the second needle. So this is manipulating the free end of that suture, passing it through the wire loop, and then pulling out through the outside, and once again tying over the capsule. So that's a way of using 2 straight spinal needles to be able to pass the suture, tying it again over the capsule, and that leaves loops on the inner side. It does make the point putting the scope in the opposite side gives a much better view of the meniscus, and using horizontal or vertical mattress sutures. So this is a technique. I was doing this in the lab with James, just using 2 spinal needles, but tying or passing the loop outside of the knee. So the suture is down the needle, but it leaves a loop. So it's just one strand of the suture is down the needle, and then through a slightly widened portal, pull that loop outside of the knee. And that then rests outside of the joint. We then take the second suture, which is going to be the definitive suture for the repair, and then passing that across the meniscus as well. So this is then going across the tear, either the vertical or horizontal suture to go past the tear, and that, again, bringing that free end of that suture out through the knee. So this is just using 2 spinal needles with a monofilament for one part and the definitive suture for the other part. The key here is that we're then doing the complex manipulation, passing one through the other outside of the knee joint. So we just pull that suture out, and then we pass the free end of that suture through the loop. So this part is done outside of the knee, and then just pulling on the monofilament then pulls that through. And that leaves then the suture loop on the inner side of the knee and tying again over the capsule. So this is a technique just using a single needle. So we pass the needle from the outside and put the free end of the suture into the knee. We then use the grasper just to hold that into one side, and then bring the first needle out and pass the loop straight back in again. So that then creates a loop on the inner side of the knee. This is just using 1 needle and 1 suture. So once that is then passed back in, we've now got a loop on the inner side of the knee, and this is in real time doing this. So now we have a loop, and the key here is to make sure the loop is anterior, the front part. So then you pass your grasper through and grab the free end that was there, if we can just pick this up, and then pull that out through the loop. So now we've got the potential for a loop on the inner side of the knee. And the 2 strands that were next to the needle as you come out of the knee, they're the ones to pull. So you pull on those 2 strands, and that pulls the end through. So now we've got a loop again on the inner side, holding the meniscus in place, and that can be tied over the capsule. So that's using one needle, one suture. So the results, there are very few papers published on outside in, but this was a review published 2012 over the history and clinical repair results 73 to 98%. This is on clinical results rather than on MRI results. And note in this paper from Russ Rowan back in 1985 that he's saying here it would appear that eventually techniques will be developed that will eliminate many of the present challenges, avoiding the need to place suture material through the skin. So even at that stage, well before the all-inside devices. There are some other different techniques that have been recently published. This one on the left is passing the needle through the meniscus so it ends up on the underside, and then pulling out the suture so you create a vertical mattress again going through the whole meniscus. And here's another technique using a curved corkscrew suture passer that was published in 2006. So there are other ways to get this achievement. Some final tips then, just to finish off with. A needle to hold the meniscus in place and testing where you're going to put the sutures. So you from outside in is a bit harder, so a test needle first to get through in the position. A grasper for counter pressure. Using sutures of different colors can help with some of the confusion of passing the loop through. The monofilament loop suture, and then the definitive, a PDS suture for tying the meniscus. So this is really indicated for the anterior 2/3, mainly the anterior third, but also for the middle third. The first suture is the hardest to be able to control the tear. It does take a bit of practice, and that's where good cadaver labs come into place, and a good assistant as well to hold the arthroscope in the right place. And as I mentioned, this needs practice. Thank you for your attention.